Thanks for giving me this opportunity to present you the REACH study. REACH study is a phase 1/2 open-label trial of hydroxyurea conducted at 4 clinical sites in Sub-Saharan Africa, in Angola, DRC, Kenya, and Uganda. The goal was treating 600 children between age 1 to 10 years. The study was conducted through the Cincinnati Children's Hospital. To enhance safety, we used Simon two-stage design, and the Red Cap website provided online dosing calculators. The hydroxyurea capsule were donated by mid-scale, sorry, the previous slide. The hydroxyurea capsule were donated by Bristol Myers Squibb. Patient began hydroxyurea at 15 to 20 milligrams per kilo per day as a single oral dose. After 6 months of fixed dose, we increased the dose. Sorry. I just have a problem with I would like to help me there. Sorry. We increased the dose. We increased the dose after 6 months to the dose was by dose escalation to a maximum tolerated dose, MTD, increasing the dose by 2.5 milligrams per kilo per day every 2 months. The MTD was defined as mild marrow suppression without toxic effects, primarily neutrophils, but also reticulocytes and platelets. The main study objectives were feasibility, safety, and benefits. For feasibility, we focus on enrollment study retention and adherence to the protocol and the medication schedule. For safety, we focus on dose-limiting laboratory toxicities, which serve as the primary safety endpoint. These were recorded of both dose and after escalation to MTD. We also recorded the rate and severity of infections, especially malaria. Laboratory benefits included changes in hemoglobin and fetal hemoglobin. Clinical benefits included Sickle-related events like pain and acute chest syndrome, plus important clinical events like transfusion and survival. 635 children were consented in the REACH trial. During the 2-month screening period, there were 29 children who withdrew for various reasons, including 4 deaths. 606 children were initially treated, and 600 received 3 months of treatment, which was marked the primary safety endpoint. Regarding retention, 89% of scheduled variants were completed, and 84% of the children remained in the study at 3 years. Regarding adherence, families were asked at each clinic visit, and 80% of these assessments recorded no missed dose. Those limiting toxicities were the key safety parameter defined here. Note the very low hemoglobin threshold, which was appropriate in the African setting where many children have severe anemia. In the first stage of enrollment, 53 children at each site were studied and confirmed safety of our starting dose. In the second stage of enrollment, the first 133 participants at each site were studied, and only 5% of the children had a dose-limiting toxicities, well below the expected 30% threshold. Laboratory benefits of hydroxyurea treatment are shown on this slide. Compared to baseline values, Three parameters expected to increase did so: hemoglobin, MCV, and fetal hemoglobin. The average hemoglobin rose by 1 gram per deciliter, and average fetal hemoglobin increased to over 20%. Similarly, three parameters expected to decrease did so: neutrophils, reticulocytes, and platelets, but without toxicity. These laboratory benefits continue through months 24 and 36 and beyond. The rates of specific clinical events are shown comparing the 2-month screening period with subsequent 6-month treatment intervals. Sickle cell-related events decreased, especially vaso-occlusive pain and acute chest syndrome. These low rates were sustained through month 36. Additional clinical benefits were observed for the rate of both malaria and non-malaria infections, significantly decreasing while on hydroxyurea treatment. The rate of transfusion was lower on treatment, and most importantly, the death rate decreased on hydroxyurea. In conclusion, our study documents that hydroxyurea is feasible, safe, and effective treatment for African children with sickle cell anemia. Hydroxyurea is associated with reduced rates of malaria and other infections, leading to improved survival. Based on our data, we believe that wider access to hydroxyurea for sickle cell anemia has the potential to save millions of lives in Africa. Thank you.